All right, we are live on Facebook and everyone has been let into the room. So I'm going to turn everything over to David.
Thank you, Amanda. Welcome everyone to today's presentation entitled The World Health Organization and Global Health Governance Lessons from the Pandemic. As an Albright College grad with a political science degree, I am privileged today to introduce our presenter, Dr. Irene Langran, who is a professor and chair of the political science department at Albright, where she also directs the interdisciplinary programs in international relations and public health. Her research interests include globalization, global health, and global governance. She has published in several academic journals, including the Journal of Asian and African Studies, Asian Studies, New Global Studies, the Canadian Journal of Political Science, the American Journal of Islamic Social Sciences, and the Journal for Peace and Justice Studies. Dr. Langran received her doctorate from the University of Toronto, specializing in the comparative politics of developing countries. The field research for her dissertation focused on health sector reform in the war-torn southern Philippine region of Mindanao. Before joining Albright's faculty, she worked with non-governmental organizations in multiple countries, experiences she brings to her classroom today. Welcome, Dr. Langran.
Thank you, David. Thank you for that nice introduction. And it's always good to see fellow Albrightians. And thank you, Amanda, as well. I also wanted to give a thank you to Dr. Adam John of Albright College, who helped arrange for this, this presentation.
Dr. Langran, I apologize. I forgot to say when I started that we want to keep all the attendees muted if possible. And if you have questions, please feel free to put them in the chat. We will be answering questions at the very end. Thank you.
Perfect. Amanda, thank you for noting that. And I do look forward to your questions and your comments. I am sure there are going to be quite a few on this topic. So I'm going to try to do my best to keep within the time limits of this presentation. So today I'm going to be speaking about the role of the World Health Organization, the WHO, and global health governance. This is a topic that is obviously in the forefront right now as we are still in a pandemic. It is a topic that is rapidly evolving. And even today, there was some major news coming out of the World Health Organization on this topic. And I'll talk about that in a little bit. So what I'm going to do is I'm going to share my screen with you. And hopefully you can all see this. So I wanted to take a moment just to really talk about what we are going to be looking at today. So we're going to be starting out by conceptualizing global health governance. We're going to talk really about what it means and how it's evolved over time. We're going to make some brief comments about pandemic preparedness. And then in terms of lessons from the current pandemic, there are a lot of areas that have been highlighted as areas in need of reform. And I'm only going to focus on 3 of those, but there are 3 that I think are really important. I'm going to be focusing on the 2005 International Health Regulations, which are the rules that are intended to help prevent pandemics. I'm going to look at the role of financing for the World Health Organization. And then finally, I'm going to close with some comments on equity and vulnerability. And then finally, we'll have a discussion and your questions as well as your comments. I think it's also interesting to note that last week's speaker at this event, Ambassador Ronald Newman, quoted General Anthony Zinni when discussing the issues of lessons and what we learn from the lessons that we supposedly see. And he noted that Anthony Zinni had said, sometimes there can be many lessons that are observed, but few lessons that are learned. And I think it behooves us to really think about the lessons we have learned from the current pandemic and what those mean for us going forward. So if we look at the current pandemic, I'm going to just share the most recent updated information in terms of the pandemic's spread. And there are a number of organizations that have done an excellent job in terms of tracking the pandemic. One of the ones that I rely on quite a bit is the Johns Hopkins Coronavirus Resource Center. If you're interested in this, this is a database that lets you search rates of COVID, even by county in the United States. And of course, we see globally that there are, in terms of total cases, we have over 267 million cases that we've had of COVID-19 to date. And the total deaths are over 5 million. So in spite of all the planning that we've done, and I'll talk about those planning efforts in a moment, in spite of all this planning that has been done for years, what we see is at the end of 2019, a new communicable disease emerged. Since its emergence, it has affected every country in the world. It has caused massive social dislocation. It has upended economies. It has resulted in political unrest. And it continues to be a challenge. And of course, most recently, we see the emergence of a new variant. So let me take you to some key concepts before I go any further. So right now, we're focusing on this idea of global health governance. And there are really three important parts to understanding global health governance. Global health governance involves how state and non-state actors at various levels, so at local, national, international levels, address their interconnected needs in health. What is significant about global health governance is that it encompasses not only states, but those non-state actors. Early efforts in international cooperation in health, which even include the 1851 International Sanitary Conference that was held in Paris, those early efforts really focused on states. Today, what we see is there are a number of non-state actors who are very significant, and they're working at all different levels. If you think about the current pandemic, it has really been shaped not just by what is happening at the international level with the World Health Organization, but it is also very much shaped by what is happening in local school districts, in local communities, at individual colleges and universities as well. So understanding global health governance is a way of thinking about how all these different actors at different levels come together to address this interconnected need. Pandemic preparedness is also a term I just wanted to mention. Pandemic preparedness, as defined by the World Health Organization, should be seen as an integral part of preparedness to threats to human health caused by any emergency. That could include outbreaks of any disease or the occurrence of natural disasters or chemical incidents. To give you a quick overview of some of the pandemic preparedness measures that have been taken in recent years, we saw that there was a significant uptick in pandemic planning that occurred after the SARS pandemic in 2003. So to give you just some examples of the many, and there are dozens and dozens of the many pandemic planning exercises that occurred in 2005, the World Health Organization and the European Commission came together for a joint pandemic workshop. Also in 2005, the United States prepared a national pandemic strategy. In 2006, the RAND Corporation prepared a tabletop exercise for influenza preparedness in local public health agencies. In 2011, the European Union adopted a pandemic foresight scenario, and the World Health Organization for years has worked on a global preparedness monitoring report. So there was a lot of work that was being done in preparation for potential pandemics before we saw the emergence of COVID-19. But because of the repercussions of COVID, many people have asked, well, what happened? What went wrong in this instance? And to that end, the World Health Organization brought together an independent panel of experts to really look critically at what happened, what worked, and what didn't work in terms of the response to this pandemic. This group was convened in September of 2020, and they issued their findings in May of 2021. This independent panel was co-chaired by former New Zealand President Helen Clark, or Prime Minister Helen Clark, and former Liberian President Ellen Johnson Sirleaf. I put this picture up of the panel during one of their meetings because over the past year, I have been spending a lot of time looking at earlier international meetings on global health matters. And they always seem to end by having a group photo. And of course, there are two things that are very different with the photo we see of this group. Much of my work has been looking at the international sanitary conferences that they had in the late 1800s. Those, when you look at those pictures, you see, of course, they are all men. They are all they look very much alike. Here we see a very diverse group, but we also see that they're participating on Zoom. And I think that really shows a stark contrast to what we're used to seeing when it comes to these international health meetings. And it's another indicator of how much things have changed because of this pandemic. I think one of the main findings and what they start with in their report is a very stark statement. And I put it here because I think it was so strong. COVID-19 remains a global disaster. Worse, it was a preventable disaster. I think those findings are quite significant. One of the things the independent panel has done is they put together an analysis of the role of different actors. I took some of the highlights of that report. They talked a lot about national governments. And on the one hand, they did note the extent to which many national governments were able to successfully develop vaccines very quickly. But they were also critical, and they noted that the response by governments was very uneven. They noted specifically that the wealth of a nation did not always indicate the success of their response to the pandemic. And I think that that is significant. They noted that many countries delayed their responses to the pandemic, adopting really what they called a wait and see approach. Let's wait and see how much this spreads. They cited many governments, or faulted many governments, for a lack of coordination, not only among other states, but a lack of coordination across the government. They talked about how a strategy to address the pandemic was in some cases inconsistent throughout the country, and in other cases non-existent. And they talked about how in many places science was devalued. The report also did not spare the World Health Organization from criticism. And it looked not only at the role of the World Health Organization, but it also looked at the role of other multilateral institutions. They did note that by having an open sharing of the genome sequence, countries were able to develop or have the most rapid creation of diagnostic tests in history. But they also noted that coordinated global leadership was absent. Global tensions among states and within states themselves were undermining the work of multilateral institutions. And they spoke in particular about how the efforts of the World Health Organization were undermined during this time. They decried the lack of funding as too little, too late. And they said, even though there were existing regulations that were put in place to prevent this, that states, the World Health Organization, and other institutions were slow to respond. Let me just take a few minutes before I go into the specifics of the World Health Organization's response. Let me say a few things about the World Health Organization. The World Health Organization was, of course, founded in 1948 with the main goal of promoting the attainment of all peoples of the highest possible level of health. It is, of course, an intergovernmental organization, and this is important to remember. Intergovernmental organizations are governed by sovereign states. States are the ones that have the power. The World Health Assembly is the body within the World Health Organization that represents all of those member states. It is the World Health Assembly that directs the World Health Organization in its priorities, in its funding, in its programs. So, for example, when the World Health Organization set out to eradicate smallpox, it was something they did under the direction of its member states, the World Health Assembly. Smallpox eradication in 1980 is, of course, seen as the greatest accomplishment of the World Health Organization. But there have been other accomplishments as well. To date, the World Health Organization and its partners have eradicated 2 out of 3 of the strains of wild polio virus, which is, of course, significant. They have eliminated malaria from more than 24 countries, And in 2003, they actually put out an international law, the World Health Organization Framework Convention on Tobacco Control, also known as the Tobacco Treaty, that seeks to limit tobacco use in countries all around the world. One of their most important endeavors, though, has been involving how they limit the spread of disease from country to country. And this is where we have a lot of discussion about reform. In 1951, the World Health Organization introduced the International Sanitary Regulations. These regulations required states to notify the WHO of outbreaks of specific diseases and then to regulate entries and exits to and from that country. The diseases that were covered were seen as the ones that were really linked to disease that is spread through travel and trade. So they included cholera, plague, yellow fever, smallpox, relapsing fever, and typhoid. However, what we also saw was when we saw HIV/AIDS emerge, and when we saw the SARS outbreak, a lot of countries and public health experts looked at the international sanitary regulations as being insufficient. They didn't cover enough diseases. They weren't meeting the threats of newly emerging diseases, which health experts were acknowledging were an increasing threat. To that end, the World Health Organization developed the 2005 International Health Regulations. The goal of these regulations is to prevent, protect against, and control the international spread of disease. It is not limited to designated diseases. It is, in fact, not even limited to communicable diseases, because one of the things that it includes are diseases, for example, that can come from radiological exposure, non-communicable diseases that can be caused by that exposure through travel, through trade. It had a couple key differences from the earlier regulations. One of the things it did, it explicitly adopted a human rights approach. And with that, it looked at the fact that there is going to be a balancing act that is needed when you look at the health of the community, public health, versus individual rights. It adopts the perspective that individual human rights should be respected to the highest degree possible while considering those public health necessities, those public health needs. It also says, instead of relying solely on states to give us information about the emergence of diseases, we're going to accept information from non-state actors. That, in many ways, was seen as being a game changer. So, for example, if you had China, a government like China who was not being as forthcoming with information, non-state actors could step in and provide that information to the World Health Organization. They also allow the WHO Director General, after consultation, to declare an international health emergency, or under its formal title, a public health emergency of international concern. This is an extraordinary event that poses a public health risk to other states through the international spread of disease, and therefore it requires an international response. One of the biggest areas that has been highlighted in terms of reform of the World Health Organization involves the international health regulations. Should they be reformed or should they be replaced? Today, the World Health Organization announced that it was convening a group of experts to consider a new international law. They will begin their work in March 2022, and they will deliver their results in May 2024. So it remains to be seen how much this differs from the international health regulations. And one thing we always need to consider is that the World Health Organization is an intergovernmental organization. It is made up of sovereign states, and those states are the ones calling the shots. The idea of investing in health systems is critical. It is at these local levels that you will be able to identify disease outbreaks. Health systems need to be able to do that. Health systems need to be prepared for pandemics. I'm just going to go ahead for a quick moment and note that the international health regulations actually call upon every member state, every of the 194 member states of the World Health Organization, to implement these core capacity requirements, to be able to have the capacity to identify diseases. But less than 1/3 of countries have actually implemented these requirements. Some people, when speaking about reforming these regulations, have talked about how other international treaties have independent monitoring. So instead of having countries self-monitor and self-report their progress, there should be external evaluation. And some experts have even called on linking funding from, for example, the World Bank to country progress on these core capacity requirements. A couple other areas in this regard that have been cited for reform include developing a tiered system of international health emergencies. So you don't simply go from not having an emergency to having an emergency. Instead, it could be different levels. And they also have cited that the World Health Organization is in need of more political independence. The Director General can serve multiple terms, but his or her ability to serve multiple terms really depends upon the approval of member states. Currently, that term is 5 years. Some experts have proposed expanding the term from 5 to 7 years, but then only limiting it to a single term in order to create greater independence. The second area I want to talk about very briefly concerns financing. The independent panel, and many experts have said, the WHO just did not have the capacity to respond to this pandemic, the financial ability. So what we see in terms of contributions to the WHO is the United States used to be right up on top there. This, by the way, all the financial statistics I will give you are from the 2019-2021 funding cycle. The WHO works on 2-year funding cycles, and their budget is, of course, set by member states. I think this list of top contributors is significant because we see that there are some states, for example, Germany, the US, the UK, But there are also quite a few non-state actors, including the Gates Foundation, the European Commission, and even Rotary International. In terms of the types of funding, there are assessments, and these are the dues for member states based on wealth and population. There is the Pandemic Influenza Preparedness Partnership contribution. And this comes from the influenza vaccine, diagnostic, and pharmaceutical manufacturers who rely upon the WHO influenza preparedness system to really prepare their products. Two other types of funding include core voluntary contributions. These are voluntary contributions that go to unmarked or unearmarked core WHO needs. But then there are specific and thematic contributions. These are designated for specific programs and activities. If you look at the funding for the WHO, one of the things that we can see is the vast majority of funding, which is indicated in this red area. The vast majority of funding is for earmarked projects. That means that the WHO does not have discretion over those funds. The assessed funds are ones over which the WHO does have the ability to direct as it sees fit. But we see that the WHO does not have a lot of control over its budget. So therefore, one of the big areas we've seen that has been discussed in terms of reform is to promote WHO financial independence through a greater reliance on assessed versus voluntary funding. And finally, I'm watching the time carefully, and I just want to close with a few brief comments about equity and vulnerability. One of the things we have seen in country after country, in community after community, is that this is a pandemic that has been very unequal in terms of its impact. If we look at issues of equity, and I'm only giving this one example from the United States, but there are many others as well. During 2020, life expectancy in the United States dropped 1.5 years, largely as a result of the pandemic. The Hispanic community in the US saw a drop in life expectancy of 3 years, significantly higher. The non-Hispanic Black community saw a loss of 2.9 years. These are significant dips in life expectancy, and they are very unequitable. Another issue concerning equity concerns vaccines. And here we have this cartoon, which I think summarizes a lot of this debate. We have Pfizer, Moderna, AstraZeneca, all these vaccines going to rich countries. And then we see poor countries that are getting very little. There is a global initiative, COVAX, which is designed to promote that vaccine distribution globally. It is made up of the World Health Organization, Gavi, which is the International Alliance for Vaccines and Initiatives, Vaccine and Immunizations, the Coalition for Epidemic Preparedness Innovations, and UNICEF. And those are the main partners. So one of the things that we can do is increase vaccine availability globally. And the independent panel in particular identified a very key target for this. They called for high-income countries to make available 2 billion vaccine doses to low and middle income countries by mid-2022. And before I close and open it up for your questions and comments, what I would like to do is just take you to a website. This is through the New York Times. And I think it is a very interesting website because it's interactive. You can note that country to country, it can track, for example, the share of the population who has received at least one dose, who are fully vaccinated, or who have received an additional dose. So we see in the US, 71% of the population has received at least one dose. If you can compare this to the Democratic Republic of Congo, 0.2% have received at least one dose. Those are very stark differences. And when we look, for example, at the rise of new variants, we know that our ability to stay healthy, our ability to go back to resume normal activities in Reading, Pennsylvania, is in many ways dependent on what is happening in other parts of the world. So I think the availability of vaccines will continue to be a crucial area in terms of being able to move forward and get beyond some of the most negative repercussions of this pandemic. And on that note, I'm watching the time, and I should open it up for questions and comments.
Thank you so much, Dr. Langran. That was great. We learned so much. I encourage you to raise your hand if you want to unmute. We can ask you to unmute at a certain time. You can put your questions in the chat as well, and we'll try to get to as many questions as we're able to. First question comes from Bernard Gerber. Has the media exacerbated the politicization of the pandemic?
Oh, that's a very good question. You know, I think I would have to say yes. And by media, I'm thinking of media very broadly. I'm thinking of traditional media, but I'm also thinking of social media. And one of the things we have seen is through this, we have had problems with vaccine hesitancy and myths about vaccine that have been circulating through social media even before this current pandemic. But one of the things that we have seen with this pandemic is many organizations, Facebook, Twitter, have had to look specifically at the role that they play in this. So the spread of misinformation has had a very serious impact on the progression of this pandemic. And I think media very broadly, the media has in some ways not been particularly helpful. And then there have been some good sources, media sources as well. But I think it's such a good question.
Thanks. Another question from Randall. Many in the US have criticized the WHO for allegedly being under the thumb of China and failing to investigate COVID origin very well because of this. Is there anything to this claim?
Okay, that is very, it's a complex question. So the World Health Organization, I think, has been justifiably criticized for being rather soft on China. On the one hand, you could say, well, China did comply with the international health regulations because they did share information. It looks though what we know now is they were rather slow in sharing that information. They were rather slow in containing the spread in China. As an authoritarian regime, there were repercussions for individuals, especially health professionals, who spoke out about what was happening. And this is where we see a lot of calls for reform of the WHO in terms of their political independence. right? Can you really have a director general who can say what they think when their term is it's limited to 5 years? It can be renewed multiple times. So can they really be forthcoming? The other thing we have, though, is the constant threat of a loss of funding. So we see that the WHO Director General is, really walking this very fine line in terms of how critical he can be of member states. The organization works on a budget that is actually very similar to a large hospital in the United States. It is less than half the budget of the US Centers for Disease Control and Prevention. So any loss of funding is significant. And we saw the repercussions when the US withheld its funding. So yes, the WHO could have been tougher on China, but there also may have been other repercussions of that. So it's a real quandary at this point, which is why if there is a mechanism that is independently trying to enforce either the existing international health regulations or a new convention, that independent enforcement could potentially encourage greater compliance with whatever regulations are in place.
I guess as a follow-up to that question, because you mentioned that the World Health Organization, the body, the assembly, they are all made up of individual member states and, appointees of those states. Is there anything in their governing documents that allows them to hold any member state accountable for something like this, for an outbreak, anything like that? I'm thinking of like UN sanctions, or there's some other international organizations where there's a little bit more of an ability to punish, so to speak, member states who act out of line.
There is no trigger that exists at this point for states that do, for example, if a state is not forwarding required information under the international health regulations, if they haven't even put together their core capacity reporting requirements, there are no repercussions. So that's why some of these reform efforts have focused on how you can enforce either these regulations or perhaps a new international law. Some have suggested tying it to World Bank funding even, or other things. So there's a lot that is being discussed in that realm. But if you look, for example, if you compare the World Health Organization to the World Trade Organization, the World Trade Organization has enforcement mechanisms for states that don't comply. So here, what we see is actually there is no such enforcement in the health realm.
Thank you. Adam, John, I'm going to allow you to talk. You have your hand raised.
I didn't have my hand raised. I'm sorry.
Oh, okay. Sorry about that. All right. I see a couple other questions in the chat. Could you discuss states' rights in the United States during the pandemic?
Sure. The United States has a health system that is described as pluralistic. So it really means that it is a system where you don't have a strong national government role. You have providers who are both public and private. You have it being paid for by public and private sources. So one of the things that we have seen is we have seen a real inconsistency in terms of how states and even local governments were responding to the pandemic. So in some instances, you had disagreements or tensions between the national government and states. And sometimes you had that tension between states and local governments, right? So I think one of the things that may come out of this, it may not, it depends really on where the country is going in terms of these discussions, is perhaps some set of guidelines or uniformity in terms of how to address pandemics. But I think the tensions we've seen are really a lack, reflective of the lack of cohesion we see in the US health system.
Question from Jay. Vaccine mandates are aimed to protect the community. How should we handle all the people who are against them? And should companies be allowed to exclude these individuals?
Oh, that is a very good question. Let me ask, I'm going to answer the second part first. Sure. I'll go back to what the US Supreme Court has said on this. The US Supreme Court ruled on vaccine mandates in the early 20th century. And it was a case involving a smallpox vaccination. And the Supreme Court ruled, and thus far it has been upheld. I don't know how it would fare today, but thus far, the Supreme Court has upheld that vaccine mandates are legal, but they also must allow for those exemptions. For example, religious or personal exemptions. So that's how I would answer that part of the question. And I'm going to look at the beginning of that question as well. How should we handle the people who are against vaccine mandates? This public health is really an interdisciplinary field, and this is where I rely upon colleagues who specialize in psychology or in communications. It is always ideal to have voluntary vaccinations. That would be ideal. But what we know is that with mandates, we do see an increase in vaccinations. And I'm talking about mandates that are specifically tailored for certain groups. There is a rationale for that mandate. So for example, healthcare workers. There is a strong case that is made for healthcare workers being vaccinated because of the vulnerable populations with which they interact. How do you convince them? A lot of the work I have seen coming out of psychology and communication studies is that while mandates work, it is important. Sometimes you need that individual communication. Sometimes you need to hear from trusted individuals, from peers. Some of the people who are not being vaccinated are people who have adopted a wait and see attitude. They're a little bit unsure about this. It's very new. So sharing information can be helpful. But there are also a lot of people who aren't getting vaccinated, and it's based on misinformation, myths. It's become very, very politicized. And that is something that is much more challenging to address.
We have another question about demographics. So how are the different demographic groups impacted differently by the pandemic in the United States when the vaccine is free and accessible to everyone?
So in terms of that's a very good question as well. We're still looking at the data that is coming out regarding children's vaccinations, that 5 to 11 age group. So we're still digging through a lot of that data. But in terms of groups where there is more of a reluctance, we have seen more of a reluctance in counties that voted for Trump versus those that voted for Biden. So that is an unfortunate reflection, I think, of the politicization of this issue. We also see that in some communities, there is a distrust that is founded, a distrust of the health system and of health professionals, particularly involving, for example, minority populations in the United States. So with that, we're seeing more reluctance to get vaccinated. We are seeing a difference according to level of education as well. So it is challenging to get through some of these obstacles. But we do see, for example, the vaccine uptake has been limited in some populations more than others. Now, we did see a report that came out recently that indicated some strong, a strong uptick in vaccinations in the US even before the Omicron variant was discovered. So we may see some shifts there.
Thank you. Is there also some of the reasons in terms of COVID deaths for minority populations due to access of healthcare and inequalities of healthcare access in the country?
Yes, so it's due to inequalities in terms of healthcare. It's due in terms of type of work. There is a difference in terms of types of work and income with people who are able to work from home, who were able to work from home during the worst of the pandemic, and those people who had to go out even before there was a vaccine. So we see that is coming into play as well. So there are a few things that are going on there.
Thank you. We have another question. Have there been attempts by terrorists to use the pandemic or vaccines as a weapon? Medical terrorism.
Bioterrorism is very real, but I have not to date seen reports of specific groups trying to use this as a weapon. It would not surprise me, but I just haven't seen it yet.
There have been some reports that the United States is donating a certain number of vaccines to the developing world and to other places. What other things can the United States do, or Germany and Europe, these countries that have access, you know, on that New York Times map, that have people vaccinated that seem to be doing better other than others, to get other areas of the world, like Africa and South America, that may not have access to these vaccines? What can we or should we be doing?
That is such a good question. That is actually something that is being discussed as part of the whole series of reforms that we're looking at. So it's such a good question. Right now, vaccine production and availability is limited by intellectual property rights, by patents. And patents, of course, exist because you want to encourage that private sector development of life-saving medicines. So they exist for a very good reason, but they're sometimes in public health emergencies, there is a need to waive that. So there has been a call that has gone out asking the World Health Organization and the World Trade Organization to come together and ask vaccine manufacturers to voluntarily share their information and allow production and distribution of their vaccines. That is a recommendation that came from the independent panel that the World Health Organization put in place. So it's one of their big recommendations. What we see also is the World Trade Organization had a series of discussions from 1986 until 1994. This was known as the Uruguay round of negotiations with the WTO. Through that, they developed an agreement. It's known as the TRIPS agreement, trade-related aspects of international or of intellectual property rights. And basically what it said was, if a country has a public health emergency, patents can be waived. You don't necessarily have to have production of those pharmaceuticals in the country that is affected because they might not have the capacity, but if it's waived for that country, those pharmaceuticals can only go to that country. So it's limited. It's not saying patents are completely overridden. So some people have said that the WTO should step in and invoke the TRIPS agreement. So that's a big issue because that could significantly affect availability of vaccines.
That makes sense. Question from Adam: which countries have handled the public health aspects of COVID the best?
Oh, that's a great question. I would actually say I would go further into that. My early research was on decentralization and health, and it was looking at local governments. So what I've been doing more recently is I've been looking at differences not only state to state, but I've been looking at differences within states. Which local governments are responding well? So there have been some studies that have come out in terms of comparing countries. New Zealand has been, for example, come up as a country that has been lauded for their response. The independent panel did conclude that states did not necessarily respond to the pandemic more effectively based on wealth. So I think that's significant. Here's another thing that people have started to explore in this community. They have noted that before the pandemic, there was a long-standing assumption that democracies produce better health results. People have started to question that now. I think that's an area that needs to be explored further. Singapore has been noted as a country that has had a good response to the pandemic. And I'm just, these aren't my personal opinions, but this is some of the consensus we're seeing in the literature. And so I think, for example, we see a lot of countries a lot of people trying to compare countries. If it's not democracy that is, driving the response and how successful it is, and if it's not wealth, what is it? There was a study that came out about a year ago that looked at gender and the response to the pandemic. And one response said, it seems that when you have a woman as head of state, you might have a more effective response. But again, much of this research is not quantified yet. We haven't seen a lot of detail on this. In India as a whole, as a country, has not, they've had some shortcomings with their response. But if we look within India, Kerala, which is a state within India, is viewed as having a very positive response and being able to really stem it through a series of public policies. I won't go into all of those now, but it's a really good question. And I think one of the big areas of research forthcoming will be to look at the relationship between the pandemic response and all these other factors.
Yeah, that's great. One last question I have. At the beginning of the pandemic, there was a lot of inventory and supply chain issues, specifically regarding medical equipment. Are there plans in place between the WHO and the World Trade Organizations that should have had the world better prepared for these types of outbreaks?
That's a really good question. At this point, I know the World Health Organization has played an important role in terms of getting that personal protective equipment to especially low and middle income countries. And that was one of the first things that they worked on. But again, they're very limited in terms of what they can do in terms of funding. And there's a lot more that needs to be done in terms of the next pandemic. The World Trade Organization, as far as I know, has not been working as directly on the medical supply issues.
Thank you. Well, I'm going to turn it over to David. Thank you, Dr. Langran, so much. It's always a pleasure. We always learn so much while you're here. I'm going to pass it over to David to toss us out.
Thank you.
Thanks.
Thank you, Amanda. And Dr. Langran, I echo Amanda's comments. We certainly thank you for joining us today and sharing your vast knowledge with us on a very, very timely topic. I did want to end today by simply noting for our members our next 3 upcoming presentations, which take us to early March. Continue to look at our website because we continue to add programs. Recall that during the pandemic, we have been endeavoring to provide 2 presentations a month, 2 virtual presentations, and that's still our goal. Although we're having trouble filling those spots over the course of the next couple months. We have a lot of invitations outstanding. We just haven't received confirmations back yet. But our next presentation is scheduled for Wednesday, and these are all virtual presentations. Wednesday, January the 19th, Peter Martin, who is the Defense Policy and Intelligence Reporter at Bloomberg News's Washington, D.C. Bureau Office, is going to talk to us about his recent book, China's Civilian Army, The Making of Wolf Warrior Diplomacy. Mr. Martin previously served in Bloomberg News's Beijing office and is very well known nationally and internationally on this topic. Moving ahead till February the 23rd, a somewhat different presentation for us. Our members have told us that they are interested in also having us obtain presentations on cultural topics. So on February, on the 23rd, we have John Gallen with EthoSource down in Morgantown, who's going to talk to us about a recent trip he took to Spain, where he walked the Camino de Santiago pilgrimage route. It's actually the 2nd time he's done this, and he's going to speak to us about history of the route and role in promoting international understanding. And the topic of that presentation is going to be a journey of the heart and soul across Spain. And then finally, on March the 2nd, in conjunction with International Women's Month, we have Stephanie Foster scheduled to speak to us on her book, Take Action, Fighting for Women and Girls. Stephanie has served for decades on the Hill, in the executive branch, especially with the State Department, and working in the nonprofit sector on promoting women's leadership, especially in the third world. And she was actually assigned to Kabul and Afghanistan for a period of time where she performed these functions over there. So really good program scheduled over the course of the next couple months. Again, stay tuned for additions to that list. And with that, I would like to wish everyone a very happy and healthy holiday season. And we will see everybody back again next year in 2022. Thank you very much. Bye-bye.